Thanks for joining us today for our Indigenous Health Research webinar series as part of the Network Environments for Indigenous Health Research Ontario. So my name is Julia Rowett, and I'm the research assistant supporting the NEAR application under the guidance of Dr. Jennifer Walker. So for a little bit of information about the Network Environments for Indigenous Health Research, for those of you who are unfamiliar, the Canadian Institutes of Health Research has opened a funding call for Indigenous groups to develop networks focused on strengthening capacity for Indigenous community-based research. The IRR is planning to fund at least one network in Ontario, and it would be a 15-year, $10.5 million investment. All of the funded networks across Canada will come together to create a national network supporting Indigenous health research. Researchers at the Mamow Ahyamowen Indigenous Research Institute at Laurentian University, in partnership with researchers from across Ontario, received one of 25 NEAR development grants to work towards a full NEAR application. Since October 2018, the network has been developing with Indigenous academic and community members with support from academic and healthcare institutions. A core NEAR committee has been meeting monthly and organizing activities focused on listening to community perspectives on what a network to support community-centered health research in Ontario would look like. The proposed collective vision is an interdisciplinary Indigenous-centered health research network in Ontario that supports Indigenous sovereignty and self-determination. This network will be structured to ensure that Indigenous health research in Ontario reflects community priorities, ethics, and protocols. The main proposed goals for the network are Indigenous sovereignty over health research, institutions reflecting Indigenous priorities and ethics, supporting emerging Indigenous researchers and graduate students, and creating a resource hub and interdisciplinary research approaches. Throughout the development of the NEAR, we have continued to nurture a close relationship with Mamow Ahyamowen, a community-based epidemiology partnership of 11 independent First Nations governed organizations serving 77 First Nations community. The Mamow Ahyamowen Partnership, established in 2016, came together with a recognition that First Nations communities lacked the health information they needed to achieve health equity in their respective communities. I would like to now introduce Fern Asinaway and Steve Moore. Fern has 15 years of experience in working directly with First Nations and their organizations in a management capacity. Most recently, she has worked as the Community Wellness Director at Sagamok Anishinaabe, and Stephen Moore is the Project Manager for Mamow Ahyamowen, and he lives in Sioux Lookout. So welcome, Steve and Fern. So Steve and Fern, if you want to unmute yourselves, I'll pull up the presentation and we can go from there.
Fern, I can't hear you yet, but if you're able to unmute yourself, I'll leave you to take those to get things started there.
If you've called in by phone, Fern, if you press star and 6, you'll unmute yourself from your phone line. I don't know if you've called in or if you've joined online.
Can you hear us okay, Fern? Huh. I can see Fern there, but maybe having trouble unmuting. Oh.
Sorry, everyone, just sorting this out.
Shall I maybe slowly start, Julia, as you're helping Fern unmute there?
I think that would be great, Steve, if you could.
Sure. So apologies, everyone, for the delay, and thanks, Julia, for the introduction. And so I'm based here in Sioux Lookout in northwestern Ontario. And it's a real pleasure to be joining everybody and talking about Mamow Ahyamowen and the Network Environments for Indigenous Health Research. I think there could be some really neat opportunities and sort of interactions there between the two initiatives. So I think it'll be neat to have some discussion around that at the end of the presentation. So I'll maybe, if we advance the second slide, what I think Fern and I were hoping to do today, and Fern, if you start to be able to speak, then just jump in and you can take over. We wanted to introduce the Mamow Ahyamowen Partnership, talk about some of the gaps that the partnership fills for communities that are involved with the partnership, and share some of the results from the Mamoising North Shore Community Health Services report. It was the first analysis that our partnership did together, and it was on mortality and the chronic conditions present at the time of death. And then finally, we thought it might be a nice segue into the discussion section to a couple of thoughts on sort of how Mamow Ahyamowen and the NEAR can maybe complement each other going forward. Great, so we'll go to the next slide, Julie. So as Julia said, the partnership was formed in 2016. Mamow Ahyamowen means everyone's voices, or some variation of that across Cree, Oji-Cree, and Ojibwe. We liked that sort of name because it's kind of like what we're doing in epidemiology. We're kind of taking all these sort of breadcrumbs of data and sort of putting them together in a sort of a single voice, or in terms of representing everybody's voices. So we thought it sort of fit with the work we're doing.
Good morning. Good afternoon.
Oh, perfect. I was just starting the background slides there. So can you see them? Do you want to just take over? I've just gone through the first two bullets on this one, and you can take from there if you want.
Okay. So you gave me the hard word. So as Stephen has already identified, we were formed in 2016, and that our name translates into everyone's voices. It's an epidemiology partnership of 11 independent First Nations governed organizations, with 77 First Nations as members in those organizations. And our vision is we are a trusted northern voice providing the health information our communities need to achieve health equity. And there's more information located on our website with the address given there. So our 11 organizations include the list on the screen now. I myself am with Mamoising North Shore Community Health Services. So we asked ourselves, what's the gap that Mamow Ahyamowen fills? And we generated some ideas. The first was it provides an opportunity. Just a second. I had some extra notes here. It provides an opportunity to enhance our research and evaluation knowledge at the community and regional levels. So for example, we do a lot of talking about the types of research that we want, and so we learn from each other. We've also had guest presenters come in from other external organizations, and we've had an opportunity to learn from those presentations as well. One in particular from the Maritimes speaks to us in terms of the process that they went through and the kinds of information that they were able to generate through that partnership and how they've used that information to advance the services and programs that are available to their community members. So the other thing is that it increases our understanding of the provincial and federal databases that hold information about our populations. I don't think that we had a full understanding before we entered into the partnership about what information is really out there and how to access that information. And on the final note, the partnership gives us access to the data that does exist about our community and within the provincial databases. So that's, I think, in terms of a major enhancement to our ability to understand what the needs are in our community. I feel like I'm talking into a void. I'm not hearing anything else. Okay, so the partnership itself provided the expertise that we needed to access, compile, analyze, and report on the information to make it meaningful to ourselves and our communities. And the local report that was generated provided an opportunity for the community and region to interpret what that information means to us at the community and regional levels, and helps to allow us to adapt our existing systems to better respond to the needs of our community. So I'm not sure, when we did the data analysis on the mortality study, that at the local level, we got a roll-up of the data for our partners within this region. So there are 7 First Nations, as well as we got an individual community report so that we know specifically where our community sits in relation to all the variables. Okay. So there's a general lack of capacity at our First Nation levels and at the regional level as well on how to access provincial databases independently. So when I speak about lack of capacity, I'm not talking about lack of knowledge and skill. I'm talking about the many competing demands that we have on our resources, our very limited resources. So instead, we entered into the partnership and sought approval from our individual communities, and the actions led to the one entity accessing the data on our behalf. It would require more resources at the provincial level if each of those 59 First Nations requested data on their own. It would be very challenging for the community itself, but also for the provincial system to accommodate all those requests. The other benefit, we felt that the ability to compare our community and regional data to better understand the information. If we had requested the data independently, we would have had to negotiate access to each First Nation one by one in order to set the context. And whereas the partnership helped us the partnership provided for prior agreement for the aggregate data to be shared amongst our neighbors. The other benefit was that it provided a full-time coordinating position that was dedicated to carrying out the necessary activities, support the goals of the partnership, and ensure that follow-up happened in a timely manner. We were able to work with the Institute for Clinical Evaluative Sciences, which brought the expertise and capacity that provided the access to access to additional financial resources to support the work. Our First Nation retained the authority as to how and if our data will be accessed. And although we have 77 First Nation communities, only 59 chose to participate. So it really remains a jurisdiction of the First Nation. So the control really rides there. And one of the things that is different from other research experiences that we've had as First Nation communities was there's definitely respect for, and the actions of the partnership are based on the principles of ownership, control, access, and possession of our data. So I'm going to turn it over to Stephen.
Great, thanks for that, Fern. And obviously, Fern, if you see interpretations in here as we go through these next slides, just jump in because you know all this stuff very well too. So when Fern and I were trying to think about how to give everybody a sense of what we're doing in the partnership, we thought one thing that might be valuable is to share some example results from the first analysis that we've done together. And so the results I'm going to show you are from one of the partner level reports for Mamow Ahyamowen North Shore Community Health Services. They did a press conference last week. Some of you may have seen some of the news, and the full report's now available on the Mamow Ahyamowen website, so they posted it there. And chatting with Gloria and Fern, they thought it was okay if we show some example slides here. So we'll if you go to the next slide. Just to situate ourselves here, the results, because the results are around mortality data, it's pretty heavy. It's fairly emotional stuff, and when we looked at the draft data, the draft reports back in January, Elder Hammond Laxul was there with us at that meeting, and he shared a few thoughts, on death and how he looks at death. And so I'll just read that quote. It says, "We don't see death as something to be avoided because we do not see death as the end of life. Sure, it's the end of our material life, but our spirit lives live on with the Creator. Our time in the material world is temporary, and then we join our ancestors in the happy hunting grounds. Growing up, I was taught that when we see the northern lights, it is our ancestors dancing in the spirit world." So I think, I think for us, we did want to make sure that when we're presenting these results, that we try to approach it with our minds in a good place, and hopefully that helps us to contextualize a bit. So maybe the next slide, Julia. As I mentioned, the focus was on mortality and the chronic diseases that are present at the time of death. The process we went through to get to doing that analysis was each of our partners was engaging in different ways with the communities they serve to try to understand what the information gaps or priorities that communities wanted help with. And we kept coming back with a number of different things. Some communities really interested in diabetes, some communities really interested in mental health or addictions. And we were trying to think about how can we move forward and help to answer some of these questions in different ways. And the mortality analysis seemed to fit well because it would give us a little bit of insight on each of those areas. So we once the steering committee had gone through that process of sort of arriving at a sort of a theme, we tried to document it in an analysis plan, and we went back to communities. Each partner went back to the communities they served with that analysis plan to see which communities would like to participate in that analysis. And so 59 of 74 communities that we served at the time, three new communities are represented by Mushkegowuk and joined the partnership more recently. But at the time, 59 of the 74 communities chose to participate, and I think that was good. There were two communities who sort of explicitly said, no, we don't want to be part of this analysis. The remaining communities we didn't hear back from, and so we took that as a no. So based on that, the analysis we went forward with was based on the involvement of those 59 communities. We got some feedback on the draft results back in January, and as Fern said, we've produced 3 complementary levels of report. So you can see in the sort of the purple or mauve there, or purple or browny color there at the top. That's the partnership level report. So that represents data from all 59 communities. You can't see individual communities in there, but all the data is aggregated in there. The green reports are the color scheme that we used for the partner level reports. That particular one is for the Sioux Lookout First Nations Health Authority. We'll be looking at the report for Mamow North Shore Community Health Services today. And then the blue theme is the community level reports. And we won't be looking at any of that today because it's not our place to share that information. So now what we're doing is we're beginning the really important work, probably the most important work out of this is getting the reports back to communities. And so, Fern has her report in hand, and as do all the other Mamow communities. But we've got more work to do with, some of the other partners and just the process of getting the results back to communities. So that's ongoing. Maybe, yeah, thanks, Julia. So just a word on sort of the data process. This data is based on sort of quantitative data. One of the things we heard from partners was that the real gap they were feeling, I think, was in terms of quantitative numbers. Partners and communities, I think, felt that they had a lot of rich sort of qualitative experiences and stories that communicate their health experiences. But oftentimes, when it came to sort of planning or prioritizing programs or applying for funding or advocacy work, often what we were hearing from partners was that the missing piece was the quantitative data. And as Fern said, some of these provincial and federal databases that communities just weren't able to access. So that was kind of the niche that we felt our partnership could usefully fill for communities. And so this first analysis linked data from the Indian registry system. So all registered First Nations people in Ontario. And we were able to link that to the databases for the people who are OHIP eligible, so the Ontario Registered Persons Database. And then that collectively got linked to the Office of the Registrar General Deaths file. So that's all the data that's on death certificates in Ontario, which includes the cause of death. And then we also linked that to the health claims and utilization databases, so physician visits, hospital admissions, emergency room visits. So you can see in the schematic there that allows us to identify sort of people in the IRS who have a specific band number, membership in a particular band in Ontario, and link that to their data in these other data sets to create quite a rich sort of picture of health there. Next slide, Julie. We used data from 1992 to 2014, so quite a long time span, and we felt that was important because we were really trying to prioritize getting data back to the community level. And by looking over that 23-year period, we were able to aggregate data so that even for fairly small communities, we were able to provide some results back. So in total, over that entire period, there were 5,837 deaths registered to the 59 communities that chose to participate. And I should say a couple of things here. One is around the methods that, if you have time to go to the full report, we've got a page and a half of sort of limitations of this work, because there are many. Some of you, who maybe who worked with the Indian registry system before, know many of its limitations. But I think we felt that this was sort of something useful that we could do within the data that was available to us. So we want to make sure that we're not painting a picture of this being sort of some sort of single source of truth or anything like that. And the other piece is that I think as we've started to present the results back to communities, a message that is reinforced time and again is that the quantitative results we're showing are not a surprise to communities or partners. If anything, they reinforce or sort of support some of the lived experience that that our community members have shared in the past. And finally, I maybe didn't make a point of this earlier on, but this work was made possible by a lot of support from other partners. And so, you know, I've mentioned the use of the Union Registry system, and we got quite a bit of help from Carmen Jones and Chiefs of Ontario in terms of, I mean, they did all the foundational work to make sure that there was a copy of that data set available at the Institute for Clinical Value of Sciences and sort of under First Nations governance there. So really, this work was enabled by a lot of work of other people ahead of us. We appreciate that. So maybe the next slide, Julie. So this is the start of the sort of the data that we're and so what this shows, the green bars are registered band members who are served by Mamwezing North Shore Community Health Services. It's the total band population. It's regardless of where people reside. So people could be, you know, you could be a band member of Batchwana and sort of living off reserve elsewhere in Sault Ste. Marie or even in Toronto, and you would be counted in these numbers, right? And the gold bars and these color schemes are consistent throughout the presentation and represent the sort of the overall Ontario population. And so you can see what's happening there, both men and women among Mamwezing community members. People are dying at much younger ages. So that's the percentages are the percentage of people dying at each of those age groups. And this will become important when we look later on at some of the chronic conditions, because some of the when we just look overall, we see that some of the chronic conditions are a bit higher rates among the Ontario population, but that's typically, I think, often, you know, it's often because community members of Mamwezing are dying at much younger ages, and so they're not living long enough to get some of the chronic conditions like dementia that you typically associate with much older ages. Maybe the next slide, Julia. So one of the sort of the headline that Mamwezing used in their press conference was this idea that over half of Mamwezing community members, 53% of all deaths occurred before retirement age. So people were dying at 65 years or less. And that compares to only 22% for Ontario overall. So that was a figure, I think, that really concerned the leadership. As I said, it didn't necessarily surprise people, but it sort of reinforced knowledge that was already there. So the bar charts you can see down below, those show this idea of premature mortality, the deaths before 65 years, compared to health units. And for Mamwezing, relevant health units would be Algoma and Sudbury there. And you can also see how the premature mortality rate compares to the LHINs. The thing I think we're really hoping that this work will help to do is try to shift the power balance a little bit. You know, I think often communities have had to go outside to look for data and information, and the gray bars here actually represent the premature mortality rates for health units, sort of for the non-registered population in health units. And that's data that the health units don't even have. So if the health units want to get this data, they now need to sort of approach Mamwezing and have a conversation. And we've started to hear that people in institutions talking about, oh, you know, we'd really like to get that data. We're always developing programs. How can we get the data? And the response we give them is, well, just talk to the community or the partner whose data you want and tell them what you're doing. And if they think the initiative is valuable, maybe they'll share it with you, and you'll start to work together on the initiative, maybe instead of working independently, which would be great. So maybe the next slide, Julia. This slide shows the causes of death that are listed on death certificates. And there's two important ways to look at this. So this is, the bars represent causes of the causes of death for Mamow community members. And the two ways to look at this are the size of the bars, so the magnitude. So by that interpretation, you'd think sort of circulatory diseases and cancers are the most important causes of death for Mamow community members. The other way to look at it is how those rates compare to Ontario overall. And so you can see for circulatory diseases that the rate is 1.2 times the rate for Ontario overall. So that's 20% higher than the rate for Ontario. For cancers, the rate is much the same as the rate for Ontario, right? Now you compare that to intentional and unintentional injuries, which is a smaller bar, but the rate is 2.3 times the rate for Ontario overall, or 130% of the Ontario rate. And similarly for diabetes, the number of deaths that are assigned to diabetes as the cause of death is smaller than some of the others, but the rate is 3.9 times the rate for Ontario overall, or sort of 290% higher than the Ontario rate. So that's quite significant. So those are the two ways to look at those results. One of the limitations with mortality data is that there are sort of secondary causes of death. There's a field for that on death certificates, but we were advised that it's not completed very consistently. And so to get a truer picture of what's making people sick or at the time of death, we decided to also look at some chronic conditions. So I think on the next slide, Julia, we show a pie graph of the number of chronic conditions that are present at the time of death. And so you can see in that green section of the pie that 58% of Mamow community members had 4 or more chronic conditions present at the time of death. Now that's lower than the proportion for Ontario overall, but remember that Mamow community members are dying at much younger ages, and so they're maybe less likely to have some of those chronic conditions associated with older age. And on the next slide, what we've done is we've showed the 18 individual chronic diseases that we looked at with this work, and you can see Christina, who's based at Laurentian, has put all these slides together and really has a knack for sort of telling stories through data visualizations. And so what she's done there is highlighted the chronic conditions where the proportion of people who have that chronic condition among Mamow community members is higher than for Ontario overall. So you can see heart attacks, addictions and substance use, kidney failure, a history of mental illness, diabetes. The proportion of people who have that chronic condition at the time of death is higher than Ontario overall. I should say that addictions and substance use is a subset of the history of mental illness. So that percentage for addictions and substance use is part of the bars for history of mental illness. And remember that these are just the overall proportions. So it doesn't consider the younger ages at which Mamow community members are passing away. And so I'll just draw your attention to the bar on the far right of the chart, the bar for high blood pressure. And you can see for Ontario overall, 60% of people who pass away in Ontario have a history of high blood pressure, compared to 50% for Mamow communities. And on the next slide, what we've done is we've taken that hypertension data and we've broken it down by age group. The asterisks indicate bars where we had 5 or less observations, or between 1 and 5 observations, and so we had to sort of obscure the data to protect privacy there. But for all the bars where we are able to show the data, you can see that there's a tendency towards higher proportions among Mamow community members for hypertension, and the reason it comes out as sort of high rates for Ontario overall when we look across the age groups is because because many of the Mawezing community members are dying at younger ages, where the proportions of people having hypertension are lower than the proportions for the elderly among the Ontario population, right? So this just highlights, I think, the importance of trying to disaggregate the data by age and sex. And so this was something that we could do when we talk about having those three complementary reports. This kind of age and sex disaggregation is something that we could do at the partner level, but we couldn't do it at the community level because we just didn't have, there just wasn't enough data. The communities are generally just too small to be able to represent the data like this. And so what Fern and other community health directors are doing is sort of looking across all three levels of reports and seeing seeing what's happening in their community, the trends that they're part of at the partner level, and what's happening at the partnership level as well. And so I think on the next slide, Julia, we just show the same sort of age and sex breakdown for diabetes data. And remember that this is not the prevalence of diabetes. This is not the incidence of diabetes. This is the proportion of people who have diabetes at the time of death. And so you can see it's maybe painting a slightly different picture than the diabetes when we looked at it. When we looked at diabetes as the cause of death, the rates appeared to be fairly low, although high relative to Ontario overall. But when we look at the proportion of people who have a history of diabetes at death, where diabetes might be a contributing factor to sort of frailty among community members, you can see that the proportions are much higher. So that's why we wanted to look at the chronic conditions as well as what's on the death certificate. There's a deeper story here. And on the next slide, we give an example of what you can see when you look at the partnership level report. So you can see that the brown line now represents all 59 communities that were part of this analysis. And you can see the trend over time for a history of diabetes at death is increasing over the 23-year period we looked at. And you can see that it's maybe increasing at a slightly higher rate than Ontario overall. And so this is an example of what we can do at the partnership level that we can't do at the community or partner level, because at the community or partner level, the numbers were just too small, and the line would be just too jagged, and we wouldn't really be able to interpret it usefully. So on the next slide, we provide an example of the addictions and substance use data. So again, higher proportions of Mawezing community members having a history of addictions or substance use when they die than Ontario overall. And I think on the next slide, we've provided a trend for that as well. And it's a bit similar to the diabetes trend, rising maybe a bit quicker over time. The next slide, we just summarize how, just looking within Mawezing community members, we can look across several different cardiovascular conditions, and we can see how the experience of women and men compare across these communities. Unfortunately, we don't. This is data based on sex, because that's what's captured in the databases. We don't have gender-based data in the databases, so we can't look at it in detail in that respect. Though interpretation-wise, that'll be important to consider. And the next slide. So there's a few of the sort of the key messages that we learned from looking at that data. Higher premature mortality rate, more likely to die before retirement age. Most common cause of death: circulatory diseases, injuries, cancer, but compared to Ontario, sort of higher rates of death among diabetes, injuries, and infections, and sort of reinforcing that point that although the proportion of Mawezing community members who have 4 or more chronic conditions when they die is lower than Ontario overall, it's probably because the community members are dying at younger ages. and so, yeah, and looking at age and sex helps us to see some important patterns. And and I think hopefully we made that point that sort of being part of the larger partnership provides communities with opportunities to see trends in data that communities wouldn't be able to see on their own. And so yeah, I think the next slide. So I'll hand back over to Fern after this slide, but I wanted to read this quote from Caroline Woodstone-Jones. So when she saw the data first in January, she said, when I look at this information, it reminds me of the wisdom and knowledge that our elders and ancestors have passed down to us. I see this information as one more way that our ancestors are able to provide us with important lessons about how we can live a good and healthy life. And I think that is kind of the frame in which our steering committee is approaching this data, is that you know, our goal now is to try to make sure that these reports don't sort of sit and collect dust, and that we do use it to improve the health of current and future generations. So out of our January meeting, as with any analysis, there's often analyses often answer sort of raise more questions than they answer. And I think for our steering committee members and the communities who were present at the January meeting, the themes that people felt we wanted to do a deeper dive on were around sort of mental health, injuries, and chronic conditions. And so we're working now to try to, with the steering committee, to try to define the scope of those three different analyses and areas. And as we go, we're trying to get as much input as we can from communities and hear how communities are interpreting the results that we're sharing back. Need to get new sort of analysis teams together to work on this data, people who have the right skill set to do the work. We need to get those new analysis plans together, and then we need to go back to communities and say, does this look like what you want? And do you want to be part of this analysis? So we've got lots of work ahead of us, yeah, it needs to be a part of it. So I'll maybe, if you go ahead to the next slide, and Fern, you want to take it from here?
Sure. So last Friday, following our North Shore Tribal Council annual General Assembly, we conducted a press conference to release this information. Our vice chair of the Tribal Council was our spokesperson, and she did an excellent job in terms of presenting the data to the press and to the community at large, as well as our president, Chief Reg Niganov, who also talked about, you know, what actions we now need to look at in terms of responding to this information. One of the most powerful speakers was Helen Bobby Wash, who is a well-known person in our regional area. She works with a number of our communities in her capacity as a consultant. She shared her personal story, and that was really powerful because it took what that data means to individuals and families and communities at the ground level. It's not just data, it's real to us, and it represents significant losses to our community in terms of the knowledge and relationships that would bring to our communities had those people survived the health conditions that our communities experience. So it was a very powerful opportunity for us to share this information and to prompt our own communities and to making plans in terms of how we can make changes that are significant at the ground level. Okay, so next slide. So I just wanted to spend a few minutes talking about what works well in our partnership, and I think at the top of the list is the respect that they show for the OCAP principles, and I think that's really clear in the fact that even though they're members of the partnership, communities are not obligated to participate in all aspects of the partnership. And so while many chose to participate in the mortality study, many chose not to do that at this time. And so I really believe that that's based on respect for First Nation jurisdiction. So we really appreciate that about the partnership. The other thing that really works well is having a coordinating position in place, because bringing 77 First Nations together and expecting each of them to conduct the work would be very challenging, given the numerous responsibilities and the many hats that each of our positions hold at the community level. So having Stephen there to lead the charge has been really an important part of the success of the partnership, I believe. The partnership has also given us access to research expertise and capacity. And as I mentioned before, I'm not trying to diminish the capacity that First Nations have. I'm saying that we have access to experts in the field of research and capacity who dedicate their work to conducting that kind of research. And so that's been a really excellent opportunity for our communities in terms of the partnership, and preparing the individual and regional reports that help us to set the context. They're very well put together. They're easy to read and clear, very easy to understand what the message is. So that's been an incredible opportunity for us at the community level to have these now and be able to share them with our communities. Community control, again, going back to those respect for OCAP principles, and I think I've spoken about that. And it's, I think what really works well is to build capacity at the regional and First Nation levels. As Stephen mentioned, the data isn't surprising to many of us. We've known for a long time that our populations carry a heavy burden of health. But to have it in such clear and concrete so clearly laid out for us, and able to use that information in terms of our planning and support at the community level is just, I can't even say how priceless that is to us, because it really gives us strong evidence that has been lacking in the past in terms of, we've relied on our knowledge of our communities, but now we have it in a concrete document that says this is the reality of our First Nation community. So that's been really great. And I think that the partnership has also provided an opportunity for us to come together on an annual basis and learn from each other. Although that happens on the conference calls that we hold each month, but that networking is really, face-to-face networking is really important as well. So our preliminary thoughts about, a potential role for NEAR is that I think that as our communities become more skillful in using and conducting research, we'll identify other research needs that we may not be thinking of at the moment. And so I can see NEAR becoming increasingly involved in projects that complement what we do as a partnership at the partnership level. Potentially provide opportunities for individual First Nations or smaller groups of First Nations to pursue research activities that may not be of interest or feasible for the larger partnership. And I think I can really see that growing as we become more ingrained in the utilization of research and evaluation tools. So I think that is one of the ones that really comes to mind for me. So we'd just like to say miigwech for this opportunity to share our experiences with you, and we're open for any questions or discussion that you may have.
Great. Thank you, Stephen Fern, so much. So I know some people have had a few questions in the group chat. If there are any questions people would like to ask Stephen Fern, you can unmute yourself and ask the question, or you can type it in the chat bar if you prefer.
I could probably start with Brian's question while other people type in or formulate their questions. But I think so. Brian had asked, "Are the rates age adjusted?" And so the rates that we only did age standardization when we did comparisons external to the First Nations population. So when we made the numbers where you see sort of 1.2 times Ontario overall, that's based on age standardized data because the underlying age structures are different. But when we're just presenting a number as the sort of the Mamow number or as the Ontario number, those are the crude rates. So we only used age standardized rates when we're actually making the comparisons, and those are shown as the multiples, if that makes sense. And
so I see a question from Sheila that says, just to verify, this is from all Ontario First Nations, no matter where they live, urban and First Nations communities?
That's correct.
Yeah, and I guess the one subtle point around that, Sheila, is that we only used the data for the 59 communities that chose to participate, but for those communities, it includes band members regardless of where they live. Does that make sense?
Great, thank you.
And that was something we discussed a bit at the steering committee level. And I think one thing that people felt was, the sort of, sometimes you think about sort of on reserve, off reserve, and there's a feeling that those categories are a little bit arbitrary, certainly rooted in sort of a colonial sort of legacy. And lots of experiences, I think, where where communities are close to large urban centers and you have many band members living just off reserve but still accessing services. You have other situations like in Northwestern Ontario here, we often have community members who have to sort of move to Thunder Bay or to Lookout when their children are going through high school or something because they don't want them sort of to be there on their own. And so I think there was a feeling that it would be a little bit arbitrary to sort of look at a subset. So I think the feeling was that the total population would work well.
So I see another question. Sorry.
Oh, yeah. I wondered if Fern wanted to speak to maybe that question on how the First Nation support process went for Mamow.
You mean in terms of how we got approval to participate in the study?
Yeah, I think Sheila said, maybe I missed it, but how did you garner First Nations or First Nations community support? Opt-in, BCR, letter?
Mm-hmm. Yeah, I can speak. The approval process varies from one community to the other, but in Sagamuk, the process is that we take a recommendation to our Community Wellness Steering Committee, and if they're in agreement and recommend it to council, then we take it to council and explain the issue that we're trying to address and ask for their agreement to participate. So we did that when it was time to join the partnership. We took it to our council and got a BCR agreeing that we should become part of the partnership. And then when it was time to implement the study, we went back to council, provided them with details about what we were planning to do, and received another BCR confirming that yes, Sagamuk would like to participate, and agreeing that on behalf of the community, the partnership could access our Indian Data Registry membership.
And I think as Fern alluded to it, it happens in different ways in each community, and I think that's one of the strengths of the partnership is recognizing that there are different approaches to this, and so I know some partners have boards that are made up of representatives or chiefs from each of the communities they serve. I think other partners use a process of sending a letter out to communities, and so it did have some flexibility in terms of the way that the arrangements that communities have with the partners they govern and how they work together.
So I see a question from Alicia. Is the work of Mamow Ahyamowen specific to First Nations community? In terms of the role for the near on, is it also First Nations specific? So Steve, I don't know, you could speak to the first part and I can speak to the second part perhaps, but that question?
Yeah, and thanks, Alicia. And we are able to produce community level results for almost all communities. There's a couple of communities that had very small populations and over that 23-year period had 5 or less deaths, and so there wasn't data that we could show there. But I think that only affected 2 of the 59 communities. So yeah, we do produce First Nation specific data, but we also aggregate it up into those partner level reports and the partnership level report, so that we can try to provide communities with as rich information as possible, as much as possible at the community level. But where that's not possible, we try to show the sex and age breakdown at the partner level, the time trends at the partnership level, so that communities have lots of ways that they can look at the information and lots of comparisons that they can make to see how their experience compares with other communities in the north here.
And Alicia, if I could speak to the second part of your question, I think this kind of addresses what we had talked about, what Fern was discussing in her slides about how the NEAR-on itself is not First Nations specific, but I think the intention of continuing to work with Mamow Ahyamowen through the NEAR would allow us to have opportunities to work with First Nations communities directly to help support new research priorities that are being identified now that these reports are coming out. But that doesn't mean that the NEAR is First Nation specific itself, if that clears up that question.
And maybe I'll try to answer Melanie's question there. So Melanie asked, how do communities access the report, specifically Moose Cree First Nation? I don't think our First Nation is fully aware of this resource. I'm currently going through the ARC process to access data. I'm not aware of this resource. Thanks, Melanie, that's great. And yeah, so I think Rob T and Sandra Kioki are the key point people at WAHA that are representing WAHA on the steering committee, and Michaela Mushkegork is representing Mushkegork. And I don't think we've produced we have the data for the Moose Cree report, but as you can imagine, with 59 community level reports to produce, and a number of partner level reports to produce and partnership level reports produce, we've been trying to prioritize, which ones we do first and sort of meet people's needs in terms of important meetings that are coming up and stuff. So I don't think we've produced the report for Moose Cree First Nation yet, but I think we can do that fairly quickly, and you could get it through Rob, Sandra, or Michaela. And you've got my email there, Melanie, so feel free to shoot me an email if you want, and I can make sure you're connected with Rob, Sandra, and Michaela, and we can work on getting that report back out.
So I see there's another question. Wishing firstly to acknowledge power of this epidemiological data analysis supported by OCAP. With this data, you've spoken about utilizing it for planning purposes. Is there support within the partnership for research as well? Sorry if I've missed this, i.e. in evaluating programs, activities, planned to address specific issues and inequities.
Yeah. I was enjoying answering the easy questions, Bern. I wonder, I know when I saw you last week, Bern, you were talking about some of the work. I think you had a colleague there who's preparing some slides so that you can try to share these results back with other team members at Sagamon. I mean, if you're comfortable talking more about that work, that might help to give some light to this question. But that's not with funding that comes through this partnership.
Yeah, when I read the question, I'm thinking that I see the research and evaluation components actually happening more at the community or regional level. That I think that what we've indicated at the partnership level at this point is an interest in digging deeper into certain specific areas in terms of mental health, substance abuse, injuries, that kind of thing. So I would see in the near future that Mamow will continue to focus on access to existing data so we can better understand the challenges. And I would see the research and evaluation happening more at the our community level for our programs and services, or in collaboration with services we receive from our regional partner, who is Mamow Ahyamowen. Does that answer the question?
Yes, they said, okay, thank you, Miigwech.
So I think that we haven't, the reports are relatively new, but we've known about a lot of the evidence that's now provided in that document. We have a strong sense at the community level that these are the kinds of issues that we've been facing. So although we just most recently got the final draft of our community report, we're already starting to look at our system and where we can make changes in terms of not letting it sit on a shelf and gather dust, because it's such important information.
I see that comment from Petron. It's always hard to know whether that's like first initial, last name, or just what it is. But so sorry if that's not your name at all. I think you were just asking if the reports can be shared or if they're available on a website. And so the reports, the community level reports, are the communities, and it's up to them to share them as they see fit. So if you want to see the Sagamon data, chat with Bern. If she, if she feels that you should see it, then she'll share it. I'm sure she'd share it with you. The partner level reports, the partners are going through their own processes for how to share those results, and that often includes going back to the communities they serve and saying sort of, what would you like us to do with this? So from Amazing, that happened at their membership meeting a couple of months ago, and their chiefs and councillors said, hey, we need to get these results out there. And so the Amazing report is up on the Amazing website, and I think I had the web link earlier in the slides. So maybe if Julia sends the slides around afterwards, you can follow that link to that report. And other partners are doing similar things. I think Slifna up in Northwestern Northwestern Ontario here is going back to their AGM in September to sort of get some direction and guidance on how to share the reports. So it's not my role to share the reports, and for Fern, she's, you know, she can share the Sagamok report, that's the one she has, and she can share the Mamow report, but we're still working through the other reports.
Yeah. So with Sagamok, it would go through our approval process. We're in the at this time we're working on preparing a presentation to our chief and council and our community wellness steering committee. And once they've seen what the data is, then it would be up to our chief and council to decide whether they were prepared to release that information publicly or not. So I can't say for sure at this point.
Thank you, Fern. Does anyone else have any final questions or comments? I'll just wait in case anyone's a little bit slow typing.
Hey, Gislyn, if you have any questions, you can give me a call.
She's giving you the thumbs up. All right. Well, I suppose if we don't have any further questions, I want to thank Steve and Fern for taking the time to talk to us about the partnership model today and thinking about moving forward how we can continue to work together with the NEAR to support research priorities from communities. So thank you very much, Steve and Fern. I appreciate it.
Thank you for the opportunity.
Yeah, thank you. Really appreciate it. Exciting initiative that everybody's working together on.
Great. All right. Well, thanks for everyone for joining us today. And if you have any further questions for Fern or Steve, their contact information is there in the final slide. Or if you have any questions about the NEAR that weren't answered or anything, you can contact me. So my name is Julia Rowett, and the email is jrowett@laurentian.ca. So I'm free to chat about the NEAR anytime if people want to discuss anything further. But with that, I guess we'll sign off for today. So thanks everyone for participating today.
Thanks.
Thank you so much.